the tracks in the spinal cord. So these are the sessions, the next three sessions. We are going to deal with all the tracks which are the ascending and descending tracks. Ascending tracks are usually the sensory tracks. The descending tracks are the motor tracks. So we are going to go into details of how these tracks are formed, where they are going to cross, and which regions of the brain they are going to be relayed. And then the final session would be mainly on the different types of abnormalities which you can see with spinal cord injuries. So we are going to talk about heavy section of the spinal cord, central cord syndrome, anterior cord syndromes, spinal shock. We are going to talk about the myelotrophic lateral sclerosis, what happens in that. So the first two sessions are mainly on spinal cord structure and the tracks, and the final session on this, which will be on next week, which is going to be mainly on different types of lesions and how the patients are going to present. So it is important that you maintain the continuity and read continuously, because otherwise you would be lost in between, because each session is building up on the next session. So if you lose continuity in between, then you will not be able to understand anything. Okay? So today we are going to start first with the spinal cord, and then we are going to talk about a little bit on the spinal nerves, and then a little bit on the tracks. But the next sessions are going to be building up sessions. Okay, so the spinal cord starts at the foramen magnum, which is the foramen at the base of the skull, from where it continues, below the medulla oblongata. So there is a foramen here, which is called the foramen magnum, and it extends. If you look at it, it is present within the vertebral canal, so it is protected by the vertebral arch in the vertebral canal, and it extends down to the level of L1, just between L1 and L2 vertebra. So it is extending from foramen magnum all the way down to the disc between L1 and L2. This is in adults. In infants, up to 1 year of age, you would find that the spinal cord extends up to L3 vertebra. So the disc between L2 and L3 extends up to this level. In the first 3 months of intrauterine life, the spinal cord extends throughout the length of the vertebral canal. So what happens later on in embryological life is that as the vertebral column is extending in size, the spinal cord does not keep up the pace. So as a result, what happens is that the spinal cord is shorter than your vertebral canal. Now the other important thing which you need to make out, that there are different segments of the spinal cord. So there are 8 cervical segments of the spinal cord. There are 12 thoracic segments of the spinal cord. There are 5 lumbar segments and 5 coccygeal and 1 sacral segment of the 1 coccygeal segment of the spinal cord. That means there are 31 segments of the spinal cord, and each segment of the spinal cord is going to give a pair of spinal nerves. So there are 31 pairs of spinal nerves which are exiting out from each segment of the spinal cord. Now do not confuse the segments of the spinal cord with the vertebral, vertebral bodies or the vertebrae, because you also have 31 vertebrae, but your spinal cord is ending at the L1, L2. So spinal segments do not correspond with vertebral levels. So if, for example, you have an injury or a fracture of L3 vertebra, there is no spinal cord there. Okay? So if the vertebral level does not correspond with the spinal level. But the other important thing which is there is that if you see the spinal nerves exiting out, the spinal nerves exit out between the 2 vertebrae. So it is going to come out from the intervertebral foramen. So between the 2 vertebrae there is a foramen through which the spinal nerves exit out. The first 6 spinal nerves are going to exit out above their vertebral level. So if you are looking for C1 spinal nerve, it is going to exit out between the base of the skull and C1. And C2 is going to exit out above C2, so it is between C1 and C2. This goes on till the 7th, the 7th spinal nerve, which is going to come out between which is going to come out between C6 and C7. The problem starts to happen with the C8, because C8 is a spinal nerve, but you do not have a C8 vertebra. So the C8 spinal nerve is going to exit out below C7 and above T1. So it is between C7 and T1 vertebra. The rest of all the spinal nerves are going to exit out below their vertebral level. So if you are looking at T3, it is going to come out between T3 and T4. If you are looking for the spinal nerve T5, it is going to be between T5 and T6. So imagine the spinal cord is ending at L1. So all segments of the spinal cord are going to end by the L1 level. So the rest of the spinal nerves have to travel all the way down to their corresponding vertebral level and then exit out. So you see a tail-like structure developing below the spinal cord. Can you see this? This tail-like structure is called chorda equina. Cord means tail, and equina means horse tail-like structure. So this, because the spinal nerves have to go all the way down and then exit out at their corresponding vertebral level, they are going to form a horse tail type of structure, which is called chorda equina. The other important thing which you are seeing is that as the spinal cord reaches the L1, L2 vertebral level, it is going to form a cone-shaped structure, and this cone-shaped structure is called conus medullaris. From the conus medullaris, you can see a fibrous structure coming out, which is going to go to the tip of the coccyx, and this fibrous structure is called phylum terminalis. So now you know what is conus medullaris. You know, yes, go ahead. Okay. So from the tip of the conus medullaris, you can see a fibrous structure going all the way down to the tip of the coccyx. And this fibrous structure is called the phylum terminalis. So phylum terminalis is a layer of pia mater and is a fibrous structure which is going from the tip of the coccyx, from the tip of the conus medullaris to the tip of the coccyx. So one thing is clear, your termination of the spinal cord is L1, L2, between the disc between L1 and L2 in adults. It is between L2 and L3 in infants. So you need to know the termination. You know what is chorda equina. You should know what is phylum terminalis, and you should know that vertebral levels and the spinal segments do not correspond with each other. Okay? Yes. I will talk about it in a minute. Give me a minute. We will talk about it. So you can see it here. Again, what we are showing is that these are the cervical segments, and you have 8 segments of the spinal cord. So and the spinal cord is ending at L1 vertebral level, so there is no way that the vertebral levels are going to correspond with the spinal segments. But when you get an injury, somebody is coming to you in an ER and you do an X-ray and you find out, for example, there is a fracture of T12. Now, you need to know which spinal segments could be involved if there is a fracture of T12. So how would you be able to correspond the vertebral levels with the spinal segments? So there is a simple formula here. So for all cervical vertebra, you add 1. So if you have C7, you would be thinking C8. If it is C6, you are thinking C7 spinal segment. Yes.
It's above. Can't it damage the nerve above it?
So we are not talking about the nerve. We are now corresponding the segments with the vertebra. Each segment is going to give the nerve which is exiting in the cervical part, it is exiting above the vertebral level. But the segment which is going to correspond with it is going to be by adding 1. So whenever you are going to look at the C1 vertebral fracture, you add 1 and you know that the spinal segment would be C2. Okay? So for upper thoracic, add 2. For lower thoracic, between 7 to 9, add 3. At 10 thoracic vertebra, you have L1 and L2 cord segments. At 11 thoracic vertebra, you have L3 and L4 cord segments. At 12 thoracic vertebra, you have L5 cord segments. And at the first lumbar vertebra, you have all the coccygeal, all the sacral and coccygeal segments grouped together. So you can imagine that as you are going down, around L1 vertebra, all the sacral segments and the coccygeal segments are together. So if you have L1 vertebral fracture, you would have all the sacral segments involved and you would have the coccygeal segment involved. So that's why it would result in paralysis of the lower limb, and it will also result in incontinence and other things. But if you cannot remember this table, there is an easier way to remember. For cervical, just remember, for cervical add 1, for thoracic add 2, and for lumbar add 3 or 4. So that will give you an approximate level with the segments of the spinal cord. So if you cannot exactly remember this table, for your general information, you can always remember cervical 1, thoracic 2, lumbar 3 or 4. So if you are going to do that, you probably are in the same range. You know that L1 would have all the sacral and coccygeal segments. Okay. Next we come to the coverings of the spinal cord. So like you have the coverings of the brain, and we call them meninges. We have a dura mater, we have the arachnoid mater, and we have the pia mater. So if you cut the lamina, or this is the vertebral arch, and you cut the lamina, you are going to see this layer, which is a tough layer, which is known as the dura mater. The space between the dura and the vertebral arch is the epidural space, and you can put an anesthesia there. You can do an epidural anesthesia by putting an anesthetic between a potential space between the vertebral arch and dura mater. Then you have the arachnoid mater. So there is a subdural space which is between the dura and the arachnoid, and then below the arachnoid there is subarachnoid space, and this subarachnoid space consists of CSF. Now we said that the spinal cord is going to end at the level of L1 and L2. So that is the disc between L1 and L2. But the dura and arachnoid are going to continue down to the level of S2. So the subarachnoid space is continuing down up to the level of S2. So you can actually take the samples of CSF by performing a lumbar puncture at the level of L3, L4, or you can perform a lumbar puncture at L4, L5. And the easiest way of doing that is just finding out the upper end of your iliac crest, and if you make a line, you will know that this is the level of L4, L5, and you can put up a needle easily without damaging the spinal cord and take the CSF out. So that procedure is called lumbar puncture. You can also put a dye into the subarachnoid space and take a radiograph, that is called a myelograph. And the reason why we usually do myelographs is this, because if you see the hair, what you are seeing here, these are the spinal nerves. Can you see?
Yes.
These spinal nerves are coming out between this vertebra and this vertebra. So this is the intervertebral foramen through which these spinal nerves are coming out. And usually in old ages you have degeneration of vertebra. So there could be degeneration of the disc, there could be degeneration of the vertebra, there could be a prolapse of the disc between the vertebra, and that can compress these nerves. Now, how would you see these nerves are compressed or not? What you would do is put up a dye into the subarachnoid space, and this subarachnoid space is continuing to the point where the nerve is exiting out from the intervertebral foramen. So your arachnoid and dura continues with the nerve, the spinal nerve, until it exits out from the intervertebral foramen. And then this dura and arachnoid is going to fuse with the epineurium. So it is the dura and arachnoid is extending to the point where the nerve is exiting out from the intervertebral foramen, and then the dura and arachnoid is going to fuse with the perineurium. So if you inject the dye into the subarachnoid space and take a radiograph, wherever you would find the compression, the dye is not going to go. So if there is a space between the two vertebrae is reduced and it is compressing the nerve, you will see the dye is not going there. So you can identify compression on the nerves by doing a myelograph, and a myelograph is done by putting a dye into the subarachnoid space and then taking a radiograph, and that radiograph will tell you if there is a compression to the nerve or not. Okay? Yes? Somebody?
But they're fusing the margins, right?
Yes, you see here, this is the dura, this is the arachnoid, and as the spinal nerve is formed, it is extending over it, and once it exits out from the intervertebral foramen, the dura and arachnoid is going to fuse with the epineurium. Okay, so that will finish up the subarachnoid space. So it is extending to the point where they are exiting out from the intravertebral foramen. Now, if you look at the spinal cord, there is a central sulcus here ventrally. It's called the ventro or anterior-median sulcus or fissure, and posteriorly there is a sulcus. So there is a fissure in front, and there is a sulcus behind. So there is a posterior median sulcus behind, and there is a ventromedian fissure in front. You can also see that each segment of the spinal cord is going to give rise to 5 to 6 rootlets. And these rootlets, there is a ventral rootlets and there are dorsal rootlets. Ventral rootlets are motor rootlets, dorsal rootlets are sensory rootlets.
Doctor, what?
Rootlets, because these are many. Can you see that? 5 to 6 rootlets, ventral, and there are 5 to 6 dorsal rootlets coming out from each segment of the spinal cord. And these rootlets are going to join together to form the root, and the roots are going to join to give rise to the spinal nerve. And this spinal nerve is a mixed nerve because it has a motor component, sensory component, and also in certain portions autonomic component also. You can also see with the dorsal rootlet there is a dilatation, and this dilatation is for the dorsal root ganglia. And the dorsal root ganglia consists of the sensory neurons present in which are going to supply the spinal cord. So there are sensory neurons, the cell bodies of the sensory neurons which are present in the dorsal root ganglia. Okay, next we are going to look at the spinal nerve a little bit in detail and then come back to the spinal cord, look at the gray matter and the white matter and the different types of nuclei and different white matter bundles which are there in the spinal cord. So the nerve, as we know, that consists of bundle of fibers, nerve fibers which are covered by endoneurium, perineurium and epineurium, which is the outermost layer of the nerve. Now, the spinal nerve, we know that it is formed by a ventral root and a dorsal root. So this is a mixed nerve, and once this spinal nerve is formed, it is going to divide into a ventral rami and a dorsal rami. It also gives communicating ramis to the sympathetic chain in the thoracic region and the lumbar region of the spinal cord. So it is going to give a dorsal ramus, ventral ramus, and communicating ramus to the sympathetic ganglia in the thoracic and the lumbar segments of the spinal cord. Now, the dorsal ramus is going to supply the skin and the muscles at the back. The ventral ramus is going to supply the muscles and the skin over the anterior lateral body wall and also